So we'll be talking about blood transfusion triggers, criteria for blood transfusion. What trigger? Why will you want to give blood? That's the trigger. That's what I mean by triggers. Complicate. Okay. Complications of blood transfusion. We'll end it with complications of blood transfusion. Okay. So generally, when the hemoglobin level is lower than 7 grams in adults and most children, that's when we decide to give red cell. 7 grams. PCV of 21 is because it's considered severe. How do you categorize anemia? Anemia can be categorized as mild, moderate, severe. When is it severe? When it's less than 7 grams. When is it moderate? Moderate. When the PCV is between 21 to like 25, or that 21. That's HB of greater than 7, but maybe 7 to 9, you can say 9 or 8. Then mild is when it's 8 and above. There's an overlap actually. That's PCV of no, PCV of 8 is 24. So it should be 9 actually. HB of 9 because it's times 3. Severe is 7 and below. Moderate is 7 to 9. And mild is 9 and maybe to 10, 11. 11 because PCV of 33 is also considered anemia. 33 and below. 33 and below. Mild is mild. So you won't give blood for mild and moderate anemia. You only give blood in severe anemia. And that 7 is not cast in stone. You can decide to give blood at 8. You can decide to give, I'm going to explain myself. Even at 9, you can give blood. For example, if someone is losing blood, you don't want to wait and is pouring out blood. You have to make blood available. You don't want to say because Akinbami said it has to be 7. You now wait until 7. You understand? Or somebody has done surgery and the wound is not healing. Has done CS. Wound is not healing. And hemoglobin is 8. I say, they taught us that it has to be 7. No, because what will make the wound heal is oxygen delivery to the wound. And if there is not enough delivery of oxygen because of reduced level of red cell, then the wound will not heal. So it's not, but if the person is stable, the person is not bleeding, the person has not gone for surgery, then you want to wait until it's 7 grams before you give red cell. I'm talking about red cell transfusion now. But for plasma, FFP, we use INR. I don't know, you are going to be learning about INR, International Normalized Ratio, by next time you are back. INR is the PT of the test, proton beam time of test, over proton beam time of the control raised to power ISI. So you are expecting, if I do your INR now, you know what I mean by proton beam time. Proton beam time. There is a proton beam time, there is activated partial thromboplastin time, there are various types. But for INR, we use proton beam time. So I do your INR now, write down the formula. I said PT of the test of the person over PT of control raised to power ISI, International Sensitivity Index, is ISI, is equivalent to INR. Is equivalent to INR, okay? We'll talk more about that later. So if I check your PT and control of everybody in this class that are assumed to be normal, and then pull their plasma together and check if your own plasma is also normal. What will be my ISI? If ISI is 1, your PT and the control, if you are normal, and then the control, everybody in the class bled, we pull their plasma together, we do a prothrombin time, we do for you too, and you are normal, then ISI, raised to power ISI, international is 1. What will be the INR? Your INR? It will be 1. Because if you are normal, whatever they get will be 1, so it will be the same. It will be close to the same thing. So if your INR, if for some people, if INR is greater than 1.6, then you give plasma. FFP, FFP, Why must you give FFP? Because it has all the clotting factors, or you give cryo, whichever one. Okay, that is the indication, that's the trigger for plasma. What about, I discussed platelet with you last week. The cutoff for platelets is patient going for ocular or neurosurgery. What's the cutoff? Platelet count 100, it has to be 100 and above. Patient going for general surgery or CS, it has to be 50 and above. Patients, asymptomatic patients, 10 and below. Patient has no symptoms, platelet is 10,000, you have to do platelet. Between 10 and 20, if the patient has symptoms like what? Bleeding symptoms like petechia, corpora, you give patient. So if the patient is going for CS and the platelet count is 30,000, what will you give? You give platelets. You give platelets. So, like I said, it's not cast in stone. That's why I'm giving you this table. Transfusion will be required less than 6 grams per year for anybody. That's species of 18, almost everybody. But 6 to 7, transfusion generally likely to be indicated. But with some, because if you are talking about HBSS now, sickle cell patients, we can tell you that my steady state is 7 grams. So why do you want to give? If you steady state is 7 grams, you will not bother to give blood now. You understand? So that's why that word, transfusion generally likely to be indicated. 7 to 8 grams, transfusion indicated in patient going for surgery, particularly orthopedic and cardiac surgery, because they will need oxygen delivery. I'm talking about red cell here, as you can see. It's also indicated in those with stable cardiovascular disease after evaluating patient's clinical condition. 8 to 10, transfusion generally not indicated, but may be considered in those with symptomatic anemia. Hemoglobin is 8 grams. Patient has all the symptoms: tachycardia, tachypnea, pallor. You don't want to say, okay, because it has to be 7. If the patient has clinical features of anemia, then you transfuse. You understand? That's why I said it's not cast in stone, that it doesn't have to be 7 all the time. So depending on the scenario at hand, you treat it case by case basis. Okay? But usually, hemoglobin of 10 grams, no, 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 no. No, even if you are going for surgery, if you are going for surgery, the surgeon will insist that your hemoglobin should be 10 grams. But if it's not up to, if you're doing chemotherapy, radiotherapy, they will insist that your hemoglobin should be 10 grams. That's PCV of 30. So if you are going for chemotherapy and your hemoglobin is 8 grams, you may be transfused, particularly if it's a myelosuppressive agent. that will further bring down the hemoglobin. Okay, so you can watch this video. But another like this, I discouraged use of whole blood last week, but occasionally we still use whole blood. For example, if there is active bleeding, road traffic accident, patient is losing red cell, losing plasma, losing everything. So you can give whole blood, you can still give whole blood. Or that PPH, postpartum hemorrhage, patients, you can still give whole blood, because usually PPH is acute, postpartum hemorrhage, or APH is antepartum hemorrhage. Antepartum is bleeding during pregnancy, during, before delivery, antepartum. And bleeding, I still admitted someone in a private facility of a bleeding peptic ulcer over the weekend. PCV was 7%, 40-year-old, 40-year-old, PCV of 7, not HBSS, A, bleeding everywhere because of the ulcer. We did a stool for occult and came back positive. And then we did gave history of hematemesis. So, and there was epigastric pain. So we given 3 pints of packed cells yesterday, or I think it came on Saturday. And then we are treating, because you have to treat the primary cause of ulcer. If you don't treat the primary cause, the bleeding will continue. Okay, so you are giving anti-ulcer drugs. Okay, while we are transfusing. So, but during surgery, you may want to use whole blood too, or myomectomy, prostatectomy. They are associated with massive blood loss. Myomectomy, if you have fibroid, at times it's okay. If you have completed your family, better you remove the uterus, because if you don't remove the uterus, you are trying to pull out the fibroid, then the person will be bleeding. But if you have not completed your family, okay, let's remove the fibroid and save the uterus. So, but those who have completed their family, they remove their uterus immediately, because it's easier to remove and less bleeding. Prostatectomy is also associated with severe blood loss because of secretions of some substances that will trigger. So other indications are when red blood cells are deficient in quantity and quality. Severe anemia. Severe anemia, you can give a packed cell or red cell concentrate because of the cardiovascular status, okay, of the person, particularly if the person is elderly. Severe malaria in children, you give a packed cell because you don't want to overload the system. Sickle cell anemia is a chronic anemia, you give packed cell, okay. And cancer patients generally, because blood loss can be seen depending on the type of cancer, as well. If it's gastric cancer, ovarian cancer, cervical cancer, they can erode into the blood vessels and cause bleeding. Okay, so indication for transfusion of platelet concentrate, we have discussed that already. Thrombocytopenia, platelet function abnormality. Indication for transfusion of FFP, we have discussed that. Disseminated intravascular coagulopathy, TTP is what? Thrombotic thrombocytopenic purpura. HUS is what? Hemolytic uremia. And liver cirrhosis and factors. Those are the reasons why you use FFP or cryo. So we'll talk about the complications of blood transfusion. So the frequency of complication of blood transfusion is usually directly related to the preparation you made before the transfusion. Most side effects of blood transfusions are mild, usually fever, chills, rigor, for those on transfusion. So the overall incidence is rare to see death secondary to transfusion, but it's possible if you have given wrong blood. You are giving A blood to B individual or B to A. So there will be anaphylaxis and the patient can die immediately. So it is not common, but immediate death after blood transfusion is 1 in 100,000 patients. Is rare. Because why should it be? Because apart from the fact that in UK they don't do handwritten, write the blood group, right? Everything is computerized. And then they will do forward and reverse grouping so that you are not likely to miss the blood group. I hope we are on the same page. So Nigerian values, we don't have figure. Okay. So you need to prevention of complication. So this starts with, from the word ensure that the transfusion order. I hope you are aware of how to write the transfusion order. But if you are the house officer, you are the doctor on duty, you must document transfusion order in the case note. And it's written as, because that's what the nurse will act on. Kindly transfuse this patient with 3 units of Paxil to run slowly within a minimum of 4 hours. 4 hours for any pint. Each pint to run for a minimum of 4 hours. Minimum of 4 hours. Should there be any transfusion reaction, kindly give IM paracetamol, IV, paracetamol 600 milligram starts, IV hydrocort. You can use 100 milligram or IV hydrocortisone, 100 milligram, or you can use 200 milligram. IM promethazine, you can give promethazine. Why promethazine is an anti-allergy for reaction? You can give promethazine, you can give chlorpheniramine. What's chlorpheniramine? Then discontinue the transfusion and inform the doctor on duty. You must conclude that that's the transfusion order. Discontinue, you must include that, because you have to discontinue the transfusion and then inform the doctor on duty. That's how to write the transfusion order. If you are writing, if you are the house officer and your medical or your senior registrar or registrar has informed you, transfuse this patient with 3 pints. So you have a duty to document in the case note that transfusion, because if there is any problem, they will hold you responsible. The nurse will say, the nurse will not even transfuse without an order from you. You must write a transfusion order. So you must have collected the appropriate sample and labeled the bottle. Send, if you want to do a grouping and cross match, what bottle do you use? What bottle, sample bottle do you use for collection from the donor, from the recipient that is receiving the blood? Grouping and cross match. Hmm? What bottle do you use? You use plain bottle. Why do you use plain bottle? You need the serum for cross match, and that red cell will be used for grouping. So you would have properly labeled, sent the sample to the blood bank, and in the blood bank they will group and cross match, and then they will return the blood cross match to the ward. Okay, and then you will write your transfusion order. Even before, as you are collecting the sample, it's better to write your transfusion order in the case notes. Write the transfusion order in the case note, so that by the time the blood comes back, you might not be around on the ward, so the nurse can just put it up for transfusion. Is that clear? So these are the adverse effects. It could be categorized into two major adverse effects: immunological and non-immunological. Okay, immunological complications that can affect the red cell, can affect the white cell, can affect the platelets, and can affect the plasma protein. Those are the immunological. And then you have TRALI. You're going to talk about TRALI. TRALI is transfusion associated lung injury. So if they ask you complication of blood transfusion, you just remember immunological and non-immunological. Immunological, you remember the white cell, remember the red cell, remember the platelet, remember plasma protein, and then remember TRALI. Okay? Well, so what I mean by, okay, let me just, we'll talk more about, so this is non-immunological. The non-immunological, that's nothing to do with antigen antibody. Complications of blood transfusion that is non-immunological. Transfusion, transmissible infection, TTI. That's nothing to do with the antigen of the patient, antibody of the recipient, this and that. So HIV can be transmitted. Hepatitis B virus, hepatitis C, syphilis, CMV. There are other infections that can be transmitted through blood, but not mentioned there because they are not relevant. Like Chagas disease in South America, Chagas and other, because they are not relevant in this part of the world. But Lagos State, you visited the donor clinic. So what they do, a pre-donation screening with a rabbit kit. If you are coming to donate, within 10 minutes, they will check for HIV, hepatitis B, and so on. So check your hemoglobin level, PCV, and check. If you are fit, 39% for male, female, I think it's 36 or 37, I'm not sure. So if you are fit to donate, then they will bleed you into the blood bag. You visited the place, you are familiar with it. So they will get a small quantity of each blood bag and send it to the screening room where they do ELISA. So they do ELISA for all this infection. So it's like double checking. So they check again whether HIV is present before they release the blood. So when the ELISA result comes back and they are negative, that's when they release the blood. So that's about TTI. In Lagos State, we screen for HIV, hepatitis B virus, hepatitis C virus, syphilis. We don't check for CMV, but CMV can be transmitted. We don't check for CMV because CMV is harmless in immunocompetent individual. But if you are immunocompromised, CMV is harmful. I hope you are aware. CMV is transmitted through what? Through white blood cell. It's transmitted through white cell. So other complications, bacterial pyrogens, and bacteria itself. Bacteria can release cytokines into the blood if they are infected, and then will cause fever and chills and rigor. Okay, the bacteria itself can cause sepsis. Then circulatory overload. If you are just bombarding the individual with blood, or plasma, everything, you can overload the circulation. That's a non-immunological complication. Hair embolism, you can put air through the giving set into the vein and then cause hair embolism. Transfusion hemosiderosis. So we are going to talk about it. Hemosiderosis is when you overload the person with iron. When you overload with iron, each packed cell contains 200 milligrams of iron. Each packed cell contains, and then you excrete 1 milligram every day. So how long will you take it to excrete iron contained in 1 pint of packed cell? 200 days. So imagine somebody taking 10 pints, 15 pints of blood, 20 pints of blood. So that can be overloaded with iron. So it's a non-immunological complication. Then finally, I'm going to talk about the complication of massive blood transfusion. Massive blood transfusion is a non-immunological. Massive blood transfusion is replacement of the total blood volume of an individual, total blood volume within 24 hours. It also has complications itself. What is the total blood volume? 5 liters. So how many pints will the person take within 24 hours to make? It will be 10. It will be 10. So if you give 10 and above in 24 hours, that is a massive blood transfusion, and it also has its own complications. Okay? So those are the non-immunological complications. I also have some videos. So I'm going to talk about one by one, but it will be brief. So talk about immunological red cell. Usually it's hemolytic transfusion reaction. Hemolytic transfusion reaction. What we call hemolytic transfusion reaction, if there are some other antibodies that will react with the recipient antigen, okay, that has not been found before during cross match, then it will be lysing the red cell of the recipients. Okay, if there are some antibodies in the plasma of the donor, so it can be immediate and it can be delayed. So it can be immediate within 1 hour of putting up the blood. So the red cells will start lysing, and then there can be pain, heat in the vein, headache, flushing of the face, chest tightness, nausea and lumbar pain. Those are the immediate hemolytic transfusion reaction. More severe symptoms are rigors, fever, because of the antigen antibody reaction. And then the cytokines also will be released following breakdown of the cells. So it can also cause fever, hypertension, there is bleeding and death, particularly if they are not the same group. If I've said if you give B to A or A to B, then it can lead to death. Okay, it can lead to death. It can also be delayed hemolytic transfusion. Patient has gone home, has been discharged a week to 10 days. The patient will start feeling feverish. It can be due to that. But some antibodies are slow acting. They will not act immediately until maybe 1 week after. And then will cause, that is for the red cell. You know, I said immunological can be red cell, can be white cell, can be platelets, can be plasma protein, and can be trally. So this is for the red cell. Okay? So the above symptom can also be seen after transfer of lyse red cell by due to overeating or inappropriate volume of blood. Although you should, because you are bringing the blood from the fridge, so you should allow it to get to a room temperature. It's not frozen, it's not, you are not thawing anything. It's from the fridge. You let it get to room temperature, and if the blood cells, if the red cells are lyse, it can also cause hemolytic transfusion reaction. Okay, before you transfuse, the cells have been lysed, because so the use of blood giving set to administer 5%, then the patient needs dextrose, needs blood. So that same blood giving set, you are using it to give 5% dextrose. It doesn't make sense. The concentration, the glucose concentration can cause lysis of the red cell. So if patient need dextrose and then need blood, so you leave the blood giving set inside the blood bag, get an infusion giving set for the infusion separately. Don't use blood giving set to give infusion dextrose. Okay, that can cause, or the use of dangerous group O for non-O recipient. You have said it before, dangerous universal donor. But for the adverse reaction to white cell and platelet, usually is described as febrile non-hemolytic transfusion reaction, because there is no hemolysis of the red cell. Usually it's similar to that of red cell, because there will be fever but that could be chills, headache, rigor. So you may not be able to say, is it due to red cell, is it due to white cell and immunological reaction, is it due to platelet, because it will still be fever. But and that's why you may need to stop the blood for the, if there's any fever, chills, rigor, stop. That's the first thing you should do, stop, and then assess before you continue. So you may need to give all those hydrocords, give paracetamol, promethazine, and watch, and then slowly increase. So if there is still a reaction, it's better to stop and take the blood, the partly used blood with the patient sample to the blood bank for regrouping and recross matching, should in case they have made any mistake, so that they will double check that it's the same group now. What is causing the reaction? Maybe white cell, maybe platelets. Do you understand? Maybe immediate hemolytic transfusion reaction. At least you be reassured that the patient is group A and the blood they are giving is group A. You understand? So you need to stop the blood and take sample and with the blood. So this is febrile non-hemolytic transfusion reaction. The patient, there will be fever, but there will be no hemolysis because it's not affecting the red cell, and that's why it's called febrile non-hemolytic, usually due to WBC and platelet antigen antibody reactions from the recipient and the donor. So antigen antibody reaction. So it's also may be associated with dyspnea, wheezing, collapse, and shock. But if you have noticed any untoward symptoms for anybody being transfused, you should first of all stop that transfusion to watch. Stop. If it's mild, give all those agents and then slowly increase it. If it is not stopping, you stop completely. Okay? But if you give a glucose reduced blood, all this reaction will not be there because they would have removed all the white cell. you know it's for somebody having recurrent febrile non-hemolytic transfusion rebel. So it's better to give a glucose reduced red cell. Give a glucose reduced red cell. Okay? So I've mentioned this. So if there's any reaction, so you take blood, they will do a direct Coombs test, they will do indirect Coombs test. Direct Coombs test, how do we do direct Coombs test? I hope you still remember. That's direct antiglobin test. You wash the red cell 3 times with normal saline and take a small alicot, anti-human globulin, and then macroscopically and microscopically under the microscope. So they will check whether there is an antibody on the red cell of the recipient that is causing hemolysis. And they can check for hemoglobinemia. Maybe the red cell has lysed and has released the content, hemoglobin, into the blood. Bilirubinemia, whether there's a bilirubin in the blood, because hemolysis will cause breakdown of the hemoglobin and then bilirubin. You can do a full blood count. You can do antibody screening and identification. If you have found any antibody on the red cell, you can do identification, but it's not for your level, and repeat the blood. So all packs of transfusion should be returned with the sample of the recipient. All pack with the sample, because there is no point returning the blood without you have to cross check whether they have given the appropriate group and do the necessary. So the management is simple. Mild febrile is to slow the rate of transfusion, treat patient with antipyrotics. When the patient requires repeated transfusion, has a history of febrile reaction. The simplest measure is to slow the rate and give paracetamol. So immunologic, this is largely non-immunological. Is This is largely preventable by blood manufacturing unit, the processing unit, the requesting physician, and supervising nurses. These reactions are more easily preventable. For example, transfusion transmissible infection, you have to screen. Okay, if all parties involved adhere strictly to the rules governing the use of blood. So these are all the blood transfusion transmissible infections: A, B, C, hepatitis B, apart from the HIV, then CMV. But I said CMV is not routinely screened for. So for bacteria, you can have Treponema pallidum or Salmonella can also be transmitted through blood. Parasite malaria, Plasmodium falciparum. So if somebody has blood transfusion and then run fever after, it could be the malaria parasite in the red cell of the donor blood. That is, so that is after the transfusion. So you may need to treat malaria. If you do malaria, then toxo can also be transmitted through through blood. But Lagos State government screens all units of blood for hepatitis B, C, syphilis, and HIV. And I mentioned pre-donation screening and post-donation screening with ELISA. Okay, so this is TRALI, transfusion associated lung injury. Could be immunological as you are aware or non-immunological. So what happens with the immunological is that the donor white blood cell antibody is directed against the recipient human leukocyte antigen or human neutrophil antigen. Okay, other leukocyte antigen and neutrophil antigens will accept the donor antibodies, white cell antibodies. So, but for the non-immunological TRALI, is the lipid product from the blood products, blood donor cells that are directed against the recipient's human leukocyte lipid products and not antibodies. Okay, so the activated neutrophil granulocytes then migrates to the lungs, become trapped within the pulmonary vasculature, releasing free radicals, oxygen free radicals, and destroy lung capillaries that can cause death. So once the lung capillaries are destroyed, the antigen antibody white cell antibody from the donor binds to the recipient human leukocyte antigen, becomes activated, carried from the site to the lungs, and destroys the pulmonary vessels. That's TRALI. Can lead to death, respiratory distress, dyspnea, and death. So blood transfusion is like it is a tissue transplant. It's just like you want to do kidney transplant, you want to do liver transplant, you want to do bone marrow transplant. It's the same. It's the same. So a pulmonary is not something you just be giving without, without need. A pulmonary capillary leak syndrome secondary to trapping causes severe life-threatening pulmonary edema, 70% requiring mechanical ventilator and 6 to 9% being fatal. So lipid-depleted red cell reduces the incidence of TRALI. So if you have removed that white cell from the red cell, are doing pre-storage or post storage after by the bedside, you can do a filter post storage. Of course, all the white cell antigen antibody would have been trapped in the filter, and so it's not likely to cause TRALI. Okay, so bacterial pyrogens are very rarely, because cytokines from bacteria can also cause chills, fever, and rigor. And then the bacteria, if you have not swabbed the site for the cannula very well, you just insert your cannula, they can push in bacteria from the skin, and then it's going to cause sepsis. So you ensure that there is a strict aseptic technique is observed after opening the set. You don't contaminate the given set. You are gloved, and then under a septic condition. Now that you leave the given set on the table, you are attending to other patients, you've opened it, you now come back, and then you put it in the blood. Then you are going to contaminate the given set, you know, all those things. And then you reuse of given set after a long, the same given set, they will keep it for days. They will use it for 3 pints, 4 pints, 5 pints. 1 week they are still using the same given set because of cost. So that can also cause bacteria. Most bacteria do not generally survive in temperature of the fridge. That's where the blood is kept. That's 2 to 6. But you still have some that are, you know, can survive, psychophilic bacteria that can survive, and that's what I've said there, in fridge temperature. So you have to be careful. More importantly, the practice of obtaining numerous units of blood. For example, in pediatrics, you know, like I said, the patient needs 50 mils and there is no pediatric bag, and then they've collected adult bag which is 500 mils. So they will put a needle, get 50 mils, transfuse the baby, leave the remnants on the shelf, and then when another baby comes, you know, all those can cause introduce infection, and then you won't know the source of the infection. So you have to return the blood, unused blood, to the blood bank. So there is what is called TACO, transfusion associated circulatory overload. TACO, transfusion associated type. You see in the HBSS, pregnant women, you are overloading the patient, and that's why it's always good to give red cell if there is need for red cell, give plasma if there is need for plasma, give platelet if there, instead of you giving whole blood. But you can do it in young vibrant people, but for the elderly, for the children, you may find yourself in trouble. The patient will become breathless, raise JVP, then there will be cancer palpitations in the lungs, and can have cardiac failure from TACO, transfusion associated circulatory overload. Okay, so you have to give whatever is needed in form of component therapy. So everything that will overload the circulation will cause TACO. So what we do for those with chronic anemia is to give them furosemide. Like that patient, we gave furosemide 40 milligram, despite the fact he was having Paxil, because we believe it should be chronic anemia. And then when you give furosemide, you are going to induce diuresis and then reduce the blood volume. Once you reduce the blood volume, you will reduce the workload on the heart, and then so to have TACO is very unlikely. So you give furosemide, you know, ensure a unit of blood is given no less, and then don't brush it too much. You are minimal, like I said, 4 hours for a pint, and then avoid transfusion at night, because at night the number of staff will be reduced, then they will feeling sleepy, they may not be able to monitor the patient very well except it's an emergency. If it's not an emergency, don't transfuse at night, don't transfuse blood at night. Okay, because of all these complications. So if TACO occurs, you give you stop, you discontinue immediately, the patient pops upright, and give diuretics. Okay, if it's still within your thrombophlebitis, inflammation of the veins, you know, you, because of the cost of cannula, you want to leave cannula for 1 week. After all, it's the same cannula is going to use for blood, for dextrose, for injection, for this and that. So if the people do it, they will leave it for 1 week, and then the patient will be complaining, ah, my hand is burning, my hand is burning, it's burning me. Say manage it, manage it. No, no. So you don't know what's thrombophlebitis, you remove the cannula, and then there will be inflammation of the veins, Okay, ensure no venous cannula is left in situ for not more than, even 3 days is too long, you know. One day, at least maximum 2 days, remove the cannula. But you know, I must agree with you that some patients have difficult veins. So if you just manage to manage one there, just leave it until you are able to finish the, otherwise you may not be able to get another vein. So, but for generally, you don't leave cannula for more than 3 days, even if the patient has difficult veins. Okay, you know, you have some vein finders now. You are aware, you just, it's like a but it's available. We have so you can use it to track the veins. And then some hospitals, for those with difficult veins, they will scan the area for vein with a ultrasound scanner, and then use cannula to insert. So air embolism, like I said, in the process of trying to input the giving set, you can, push air so into the, so once you push the giving set into the blood bag, then let the blood runs through the giving set to the end before you connect it to the cannula. If you don't let it run to the end, air can enter the giving set, and then you're going to push air into the vein and cause air embolism. So you must make sure that the blood runs through the giving set to the end of the giving set, and then spill a little to be sure there's no blood, there's no air. And then before, you can always ensure you read the set of air before connecting. So I've discussed transfusion hemosiderosis already. 1 unit of blood packed cell has 200 milligram of iron, and 1 milligram of iron is excreted per day. So unless a patient is actively bleeding and therefore losing iron, iron accumulation is inevitable in those that are going to be chronically transfused. So as a rule of thumb, anybody that has, I'm rounding up, anybody that's been giving adults 20 units of blood, or children with 12 units of blood, you have to give iron chelators. Or if there is money, you do iron profile study. So, but if you cannot do iron profile, 20 units of blood in iron adults, 12 units in children, you must give iron chelator to prevent hemosiderosis. Massive transfusion, I've discussed it, and some of the complications of massive transfusion is uh, acidosis, hypothermia, dilutional thrombocytopenia, citrate toxicity, hypocalcemia, hyperkalemia, among others. So these are the complications of massive blood transfusion. Best of luck. So we'll meet on, okay, let me see this one.